Thank you all. Thanks for the invitation, and thanks for arranging for the nice weather. Having moved out to Southern California, my blood's thinned a bit, so I can't do cold anymore. So today I am going to talk to you about storytelling. And I'm going to focus on the concept and value of narratives for medical education. Then I'm going to spend some time describing some of the stories that medical students tell, and then figure out what we learn by listening to those students. So lessons for medical education and for medical practice. And I'm going to first start with a commercial. This is my book. And as a commercial for next month's lecture as well, Tris Engelhardt has a chapter in here that is really addressing the incoherence of bioethics. So you might want, if you want to preview, get your hands on a copy of the book. But I put it up here because bioethics education is just seen as a good now. It's required by the LCME. We can't get away with not having it. We need it to get at that art of medicine stuff that's all touchy-feely that we can't get to with the basic sciences and unfortunately don't usually get to with clinical sciences. But bioethics is also critiqued, and it's been increasingly criticized for being unpractical and not helpful. My medical students tell me this all the time. This isn't going to help me. Understanding the definition of autonomy is not going to help me. Knowing who Immanuel Kant is not going to help me. And I try to convince them otherwise. But they have a point to a certain extent. They also accuse bioethicists, they meaning internal and external critics, of being myopic, that we focus on these big sexy issues that get us into the newspaper. Terry Schiavo and stem cell research and reproductive technologies, and we kind of ignore the mundane stuff, the informed consent process, the physician-patient relationship stuff, and we don't do as well with those issues. So rather than focusing on hot topics, in order to walk the walk that I've written about in the book, I'm trying to make ethics both practical and helpful for the medical students. So here's one of my classes, and these are some of my favorite students who agree that bioethics is practical and helpful. And the two over here on your left are two of my colleagues who helped me with the study I'm going to talk about. Johanna Shapiro, who is a content analysis expert, and Desiree Lee, who helped teach a PhD in religious studies how to count things so that I could actually report the results of the study. So my teaching method. I've been for a long time intent on using small group discussion, reflective practice, narrative work in my teaching because I think it makes more sense if the students come in and tell me what they're experiencing. And then I can help them work through what that means and how they can learn from those experiences. So my focus is on real student experience, and I want to validate their experiences, reassure them that they're not alone, and hopefully habituate them into reflective practice. So they actually spend time thinking about what it is we ask them to do every day. The goal in my classes, in this class in particular that I'm going to spend time talking about, is to elicit student values, stories, conflict management strategies. And this is a class that I do in the OBGYN clerkship, specifically to get at issues of personal values that conflict with professional obligations. I situated it there for the obvious reason lots of students will have issues with termination, with contraception, with some of the things they see in the OBGYN clerkship. Not that those are the only personal values under duress, but those are the most obvious ones for the students that are a little more narrow-minded and can't necessarily otherwise get their heads around the assignment. The student task then is to identify the conflicts that they're experiencing, the personal versus professional, although they often don't recognize the difference. My theory or my hypothesis there is that these students have been trying to be doctors for so long. And with the pre-med curriculum, and a lot of them will tell you ever since I was 5, I wanted to do this, at least that's what they write in their admissions essays, that I think sometimes they can't any longer separate themselves from the professional role they're trying to attain. So they submit these assignments to me a week before the class, so I actually have time to read them before class. They're not graded, which helps a lot. They have to complete the assignment in order to pass their clerkship, so I have that leverage over them. The assignments get done, but they're not graded. And I promise them confidentiality, so they know that what they write in the paper is not going to go anywhere else. That, in fact, we have a portfolios project, and the portfolios folks really have wanted to get their hands on these papers to put in the portfolio, and we've said no, because we want the students to be frank and open, and they really are. I mean, it's kind of stunning sometimes just how frank and open they are in these papers. But I do give them a set of 6 structured questions, And we invite them to give open-ended responses. They are not yes/no questions. And then we use the stories that they tell to discuss in class. So the class objectives, and again, the class is actually entitled Reconciling Personal Values and Professional Obligations. And their objectives are to identify and understand their personal and professional values. So we spend some time trying to tease those concepts apart. What distinguishes them? Does it matter if they overlap? Should they overlap? And then to distinguish between their personal moral conflicts and their professional ethical conflicts. Because a lot of what they write about actually ends up being an ethical conflict, a sort of a traditional nature, until we really dig into it and figure out what personal values are maybe influencing or even driving the conflict. And then we try to analyze the values conflicts that they experience to try to learn from them. What will you do about this in the future? Are you uncomfortable with how you handled it? Should you change? What should be different? What should be the same? And this is the actual assignment in abbreviated form. I first asked them to identify a situation of conflict between the ethical obligations that they have as a healthcare provider and their personal moral values. A lot of them will tell me they didn't experience a conflict, and if that's the case, they need to explain why, and then they have to answer the remainder of the questions based on sort of general conflicts they've experienced throughout medical education, or ones that they've heard about. The second question is to describe their guiding moral values. So I actually asked them to sit down and think, what are the moral values that drive you in your life, and how do they affect the situation? And then in the third question, I asked them to describe their ethical values, or the principles that are underlying what they perceive to be their professional obligations, which makes for another interesting set of conversations. What are your professional obligations? Where do you think they come from? Very interesting notions of professionalism that come out of these groups. Then I asked them to discuss their controversy in society. What's at the root of it in society? Because I'm trying to contextualize their conflict. Is it just an issue with this patient, or is there something larger societal at play? Then I asked them how they handled the situation, and then what they have learned and how they might handle a similar situation in the future. Now, over time, I started seeing a lot of themes emerging. I've been teaching this class for 5 years now, and over that time, there were just a lot of stories in common, a lot of issues in common, and I wanted to figure out a way to determine if that was just my sense, or if there really were some commonalities emerging that I could build on, that I could use to inform my curriculum. So my hypotheses, because my colleagues who actually do social science work tell me I had to have hypotheses, were that reflective practice exercises can reveal how medical students address ethical conflicts, and that in turn can help us teach them how to address those conflicts. And then that third-year medical students need more practice to develop the nuanced critical thinking skills necessary to help them address ethical conflicts. And I think my study really shows that they aren't good at that nuanced stuff. And I'll get back to that in a minute. So how do you address these hypotheses? Well, I started looking into the whole world of narrative medicine, which, I'm a PhD in religion. I hadn't done a lot with literature, but of course I'm struck by the kinds of stories that are being told. So the definition of narrative medicine is that it's the ability to critically understand and be moved by the patient's story. And I started thinking, well, what if we wanted to critically understand the student's story? I'm frequently moved by them, so it seemed I was onto something. I looked to the literature. There aren't any student stories. We all have them in our medical schools, and sometimes we have these arts journals or projects that we engage the students in, but there's not a lot published. The literature really focuses on patient stories. Unless the student or the physician becomes a patient, they don't get to tell their story. At least they don't get it published. So I wanted to figure out how to get these into writing and then use them educationally, if not for publication. And I started looking at why patients tell stories. Were there overlaps? Could I really draw on this field of narrative medicine? The functions of pathographies, or stories about illness. I found patients tell stories to get better, to orient themselves into the world of illness, to make sense of their life, to see it as meaningful, the symbolic integrity notion, to show capacity for change or the ability to overcome their negative circumstances. Look how well I did. Look how brave I am. a moral action to be heard or to find support. Now, that kind of resonated with me. Why do doctors tell stories? Why do students tell stories? Well, it's really the same reasons. To get better, though, is here they're venting their frustrations. And anybody who spent 10 minutes with medical students has probably been subject to some venting. To orient themselves, they're trying to fit themselves into a whole new world. Now, the medical world is very different from the rest of reality. Symbolic integrity, again, they're making sense of their role, not just as future physicians, but as medical students now. There's a whole sociology that goes along with that, and they need to see that as meaningful so they can survive this 4 years that we put them through. In movement, again, they want to demonstrate capacity for change, although that can sometimes be interesting. Sometimes it's the socialization into the medical world. Sometimes it's resistance to it. And then the power of person over circumstance. They're trying to overcome what is wrong in medicine because our medical students all know best, right? They know what the curriculum should look like. They know what they need to know. They know how to make medicine better. And then to engage in moral action. They're looking to join with others, to seek support to get through their educational experiences, to get through their residencies. And then they want to exercise their voice, their personal moral agency, which sometimes we forget to remind them that they still have, despite putting on that white coat. So I thought, this is going to work. I can use narrative techniques to try to figure out what's going on with my students. So what do the student stories tell us? Well, I looked at almost 300 papers collected from 3.5 years of students. They were submitted between July 2002 and January 2006. So I was sort of waiting for some of the students to graduate before I really started using their papers. Now, I de-identified all the papers, so we used them anonymously. It was a retrospective descriptive study, and because of that, it was approved as exempt, actually, by our IRB. So I did go to the IRB so I can publish the results if I can find someone willing and interested to take the results. The anteater, by the way, people always ask me about that, UCI mascot. The story there, it's a UC. All the UCs were supposed to be bears. The Bruins. Well, UCI students said, no, not going to be a bear. So they went to the antithesis of the bear, the anteater. We thought, or the students, I wasn't there at the time, the students there thought they were being very resistant until they discovered that the students at UC Santa Cruz elected to use the banana slug as their mascot. So they one-upped us. So here are some of the kinds of things the students wrote about. And these are just snippets of the larger narratives that they provided. I feel helpless at not being able to inform the family as to what we know. They're all looking to us for answers, and we have none. I feel torn between acting as a member of the team, limited in what I can say, and morally feeling as if someone should sit the family down and discuss the hard reality of the patient's condition. A fairly common conflict. A second one, in dealing with difficult family members, I could protect her from having another abortion by not revealing the gender of the child. On the other hand, this may harm the patient in the future. If a girl is born, then who knows what her husband could do to her, since the relationship seems abusive. Student really torn there, didn't know what he should do. And a third one, being pregnant is in vogue these days, but to have what is called the cesarean on demand solely for cosmetic purposes goes against my personal belief system. So you can see the students are wrestling with some interesting stuff. And you can see the personal values emerging in these stories. This isn't just a matter of your professional obligations. They're really stuck by what they feel is right and wrong. Now, we asked them about the sources of conflict. Where do you think the problem is coming from? And there was a lot of patient blaming. Over 60% of them said, it's the patient. She's got a screwed up value system, and that's making problems for me. But they were also introspective enough to recognize that they themselves were often the source of the problem, 57.5%. Now, the reason these numbers don't add up to 100 is because we looked for multiple sources. So if there was more than one, we coded all of them. Interestingly, they didn't blame their supervisors very often. And that was very surprising to me as the instructor for the course, because we spend a lot of time in class complaining about residents and attendings. Now, I don't know if that's because they were worried about putting those things in writing, or if because it truly is a small subset, just the ones that trouble them the most. So I don't know. That I need to do a little more work on to figure out. But they only said the residents were the source of the problem a little less than 16% of the time, and the attendings a little less than 8% of the time. And they only blamed team dynamics, this low man on the totem pole kind of feeling, about 10% of the time. The results were really interesting too. These were the top 10 lists of personal and professional values. And you can see there wasn't a lot of overlap. And this was again interesting because based on reading the papers and my experience in class, it felt like the values were a lot more concordant than that. But they turned out not to be when we actually counted up what they listed. Now, I thought it was interesting that for personal moral values, others was actually the biggest category. That included everything that got only one, listed only one time. And there were, the variety there was huge. My list went on about 50 different values. But beyond that, you see religious beliefs and faith were their second most compelling, which actually didn't surprise me at all because we have a very religious student body at UCI. Now, the overlap, respect, and honesty, which were good values, I think, to have in overlap. Over on the professional values side, what's interesting here is they listed beneficence, non-maleficence, and autonomy. So, yay, they're paying attention to my ethics classes. Problem is, I didn't get the sense that they really knew what those were. They didn't truly know how to use them. Because as we read the stories, it didn't seem as if those values were truly working, except for autonomy, which they appeal to like, the golden handle that they can grab onto to pull themselves out of virtually any dilemma. So, very interesting results. Now, when we asked them what they did and compared it with what they would do, again, the results were really interesting. For how they handled the situation, more of them claimed that they did something about it. They acted within the situation. And that was defined to mean empower the patient, educate the patient, stop something from taking place. They acted within the situation about 35% of the time, so over a third of the time. But a lot of them actually said they did nothing. 23% of the time, they did nothing. And a lot of that goes back to that low man on the totem pole kind of syndrome. I couldn't do anything because it's not my place. It's not truly my patient. I'm not in the role to do it. I couldn't take on the authority figures. They did nothing. And they seemed to think, when we asked them what they would do in the future, that universally that was bad, that they should have done something. So you'll see do nothing in the future under 4%. So they would do nothing in the future. Most of them said, again, they would act within the situation. They'd take action right away to make sure the wrong was righted. But the rest of them said they would educate or empower themselves. So again, they're grasping at this notion of education. If I just know more, I'll be able to fix things, which I thought was really interesting because study after study shows that education is not the primary lever of change. So here's an example of the did versus would do. And here's a student who did nothing. I didn't know what to say or do or even feel. So I told her that the resident and I would return shortly to discuss her options. I never went back. But what would you do in this future situation? She would act to educate the patient. I learned that I was such a coward. I was asked my opinion on a very important issue and didn't even respect her enough to share my views. In pondering the situation deeply, I think that if asked, I had an obligation to share my beliefs to this patient in a non-judgmental fashion. After all, it was not long ago when that patient's views were probably not that different from my own. Perhaps by allowing this patient to explore my thoughts, she would have had another tiny piece of information that may, or might not have, influenced her decision on terminating the life within her. Now, I will never know. Now here's a situation where the student did nothing and was really much more disillusioned. So the situation happened so quickly that I didn't get a chance to say anything. For a while, I even tried to talk myself out of what I had seen take place. I asked the resident later, and the reply was that he had discussed it with the patient before. I did not pursue the matter any further. Unfortunately, this was a situation that made me realize that there are many flaws in the way we practice medicine. I have heard a lot about the importance of proper documentation, but I have also witnessed several other instances of indifference and negligence. And this paper goes on to really demonstrate that sense of disillusionment. In fact, you get to by the end of the paper, you're questioning whether this student should actually remain in medicine. So we wanted to try to figure out a way to capture what the students were telling us in a broader way, so that we could make sense of what they were telling us, give it a more global context. So we looked to narrative types. Now, we've all heard of different types of stories. There are comedies, there are dramas, there are docu-comedies, all kinds of different categories. So these were the categories that we went to, and we built these based on the work of Arthur Frank. The wounded storyteller, stories of illness. He's come up with these categories, but he uses them again for patients. So we thought we'd figure out a way to apply them to the medical students, because, as I mentioned before, the students tell similar kinds of stories. They use storytelling for similar reasons. So we thought we'd see if it worked. These were the categories we came up with. First, this notion of restitution, where a conflict is quickly resolved by appeal to an overarching value. And this is where the students really invoke autonomy. Everything comes down to autonomy. If I just respect what the patient had to say, that will solve all of my problems. Chaos was another category that Frank uses, where conflict appears unsolvable and the student feels demoralized. They just can't get a handle of what's going on around them. And I'm going to describe these further as we go on. Third category is compromise, where the student adheres to the perceived values of the medical profession, yet still feels the choice they made was wrong. And there's the journey. The student struggles for resolution and is changed by the experience. And there's witnessing, where there's no immediate apparent solution, but the student is at least empathizing with the patient. Resistance, where the student chooses personal values regardless of the professional ethics or pressures. And then finally, for those students who truly said there was no conflict, the student claims there's no dilemma that's been encountered. There's just nothing for me to write about. Now, we tried, even when the students said there was no conflict, to take the rest of their comments and fit them into one of these other categories. So we ended up with very few no conflict.
I just want to ask, why number 3 is compromise? That I usually think of compromise as coming from both ends. This seems like capitulation.
Yeah, we've called it, he's asked why compromise is a negative category. And that was my question too. And one of the reasons is because that's the way Frank uses it. And really, I think accommodation might be a better, or capitulation might even be a better descriptor for it. But here it's that sense that the student is compromising their values. Yes?
In terms of the categories that you used when you did your coding, for a single paper, or did you do it by question? I mean, how did you code? And could you have like 2 or 3, or each paper only got one category?
Each paper only got one, and we looked. Yes. Oh, I'm sorry. Repeat the question. In terms of coding, she asked if we coded by question or by overall paper, and if each paper could be in more than one category. We looked at the paper overall rather than question by question, because we wanted to get the whole narrative thread, so not just question by question. And we tried to fit each paper into one category only. There were some. Our inter-rater reliability here was about 75% after we did some adjusting. So we kept tweaking it until we started getting it right. But for every paper where there was disagreement, we went back and adjudicated. So all 300 papers got reviewed multiple times to fit. And usually one of the categories of story did really dominate. So there weren't many that were kind of right on the edge. There are some elements you could argue could go into another category, but storytelling's not really clean. So this is why this is qualitative research rather than quantitative.
The students often appeal to an overarching narrative. Or is this just their narrative in response to perceived dilemmas and ethical and moral conflicts?
Mm-hmm. He's asking if students often appealed to an overarching narrative or if this was just the narrative perceived in response to a particular kind of conflict. I'm going to get to that. So these were the categories we used. And then we struggled with the next question. This is a literary endeavor, so to be or not to be, to categorize or not to categorize. We really struggled with that. Are we imposing on them inappropriately in a way that we're going to be creating this risk of labeling? Are we going to minimize what they're telling us, reduce what they're telling us? We recognize that there's the importance of creating this personal space, to recognize individual variability, the complexity, the differences among the stories. And I think we do that in the literary world. Just because something's a comedy doesn't mean it doesn't have elements of other important facets of storytelling. And we certainly don't lump all the comedies together as if you've read one, you don't need to read anything else. And so we thought there really was value to this, that it could help us make sense of the stories the students were telling us, and ultimately could be a tool for the students themselves, if they can recognize the kind of story that they're living in. If they're not happy with the way the ending's going to turn out, can they do something to change it? We thought it'd be a way of deciding whether the student's story is well matched to their circumstances, or if they need to tell another story. And can we help them with that? And then provide awareness and guidance for educators to shape those stories. Because if we don't know there's a problem, we can't address it. So here we can figure out, is there a problem in the kinds of stories that they're telling? So ultimately, the labeling idea, the categorizing won out. Here's what we found. You can see great variety. So there wasn't a single, I kind of thought there'd be a lot more in one of the categories. And there weren't. They're really very diverse. So 38% told restitution stories, of course, just from this sample of papers. 16% told journey, 16% compromise, 13% witnessing, 9% resistance, 7% chaos, and only 2% remained for that no conflict, no problem category. Despite having many more papers where they said there was no conflict, they then went on to say, but, and that's the but that we pulled the storytelling from. I thought actually there would be a lot more compromise. My sense from sitting in the class with them was that there was a lot more compromising of personal values going on, but it turned out not to be the case. I was hoping that there would be more journey, because after all, education is a journey, right? But there wasn't as much as I was hoping for. That restitution category really was the biggest one, and that's a pretty sizable majority out of this group, I think. So here's what restitution looks like. We called it the find it and fix it story. That's why it's so interesting that autonomy was such the important overarching principle. You grasp onto autonomy and that solves everything. That's the most important principle, so I just respect the patient's wishes. And even if it's not what I would want to do, and even if I'm troubled by what's happened, that's okay, because it's the right thing to do. Restores order and balance, and the students are no longer troubled by it. It's not keeping them up at night anymore. And this is the story. You rely on a tangible element of guidance. So that single overarching principle that is, again, tangible. You can grasp it. You understand it. It restores balance, and it's highly desirable for all involved because it takes care of the problem. And this is really the model of medicine. Find it and fix it. You're skiing. You have a tragic catastrophe. You break your leg. Go in. Get it casted. Fixed up. And a few months later, you're back out on the slopes. Find it and fix it. Excuse me? And then repeat. Right, until the doctor says, no more skiing for you. But this is kind of the model of medicine. The auto mechanic metaphor. We go in, we get things fixed up, we send the patient back out. All done. Happy ending. Patient's cured. And we see a lot of these, quick care, walk-in urgent care kind of centers cropping up. That's the model of medicine we're talking about here. Now, this isn't bad. And let me preface my description of all of these story types. None of them are bad. They're simply descriptive. If it feels bad to you, to the person living in the story, the antagonists and the protagonists, then we need to adjust it. But every one of these stories is appropriate at certain times. We just have to figure out if we're matching those times to the appropriate situations. A literary example. for restitution stories. This was actually written by a third-year medical student a few years back, who shall remain nameless here. Today I woke up really sick. Mommy took me to the doctor quick. He gave me pills, he checked my poo. Before I knew it, I was good as new. For each of these, I'm going to provide a literary example and then a student example. So here are some student examples of restitution narratives. It's important to me to consider all perspectives when making a decision. I believe that the patient has the authority to make the final decision. So I let the patient make the final decision, and I'm done. That's the end of my story. It's fixed. I gave the patient all the information necessary for her to make an informed decision. I discussed with her the options available in the decision-making process. And again, patient makes a decision, done. So as I said, this notion of autonomy, it's not even respect for autonomy, it's autonomy almost imposed that the students are appealing to solve their problems. I didn't like the choices the patient made. Over and over they tell me in class, didn't like the choices, not what I would do. And when I ask them, if this patient was your sister, how would you have responded? And invariably, they're very different responses. So we spend a lot of time trying to figure out, why is that? Why is it okay to allow your patient to do something you think is wrong when you would never allow a family member to do it? And what does that do to you? If you're leaving the room feeling like your patient's doing something that you actually consider wrong, not just bad, but wrong, but they still find this a very appealing narrative to tell because it's easy, they're done. And then they don't worry about it when they walk out of the room. Did you have a question?
Yeah, I was going to say, you kind of are answering it right there. It seems like you could see that in one of two ways. And an appeal to autonomy to get out of the act of having to worry about the kind of paper over the internal conflict versus a real deep-seated belief that that value truly trumps either side. Did you see that come out at all? Or were ones that were more like my first category maybe fall more to the compromise category? Because I could see autonomy as a way to get from compromise to restitution, at least on paper, if not internally.
Right. He's asking if they're using autonomy as a way to kind of paper over the problem so they don't have to worry about it, or if they truly are appealing to the principle of autonomy in a sort of authentic way. And I think the answer is mixed. I think there is a lot of papering over, and a lot of that happens, I think, because they think that's what they're supposed to do. They think that's what we're teaching them. I sometimes feel like when we give them this toolbox of ethical terms, these principles, that it's like handing them a bow and a quiver of arrows and not teaching them how to use it. So they can't quite aim that autonomy arrow correctly. And I feel like they don't truly understand what that means. But it becomes I'll get done with it and I'll move on to the next patient. And they don't feel the, I guess I'd call it moral erosion that it's doing to their own moral sense, their own soul, until much later.
There could also be moral growth, couldn't it?
Moral rules?
Moral growth, to recognize
moral growth.
autonomy instead of to resort to a kind of hostile non-maleficence.
Mm-hmm.
I'm uneasy by saying that first option thinking about autonomy is the paper over option.
Mm-hmm.
Because we don't want our physicians to worry themselves to death about decisions over which they have no control.
Mm-hmm.
You don't live with that sort of guilt and shame all the time.
Of course not. He's suggesting that perhaps this appeal to autonomy is actually a sign of moral growth, that they're learning they can't always impose their own beliefs on the patient. And I would argue that that's true some of the time, that it is very important for students to learn when they have to restrain their own beliefs, when they can't behave like the parent, the paternalistic model. But at the same time, I feel like sometimes it's just too easy of an out for them. And they brush it aside because they don't want to have to worry about it. So it's stunting their moral growth rather than aiding it. But I think it goes both ways. One more question and then I'll move on.
There is a certain personality type who believes in the superiority of their decision making.
Yes.
And yet they avoid all opportunities to assume the risk and responsibility of applying that decision because it might turn out to be not the superior decision.
Right.
So in this case, they can leave with their decision in place and not have avoided all the risks and responsibilities of applying.
Yeah, she's suggesting that there are a certain set of students who have that sort of moral superiority sense, and that this might provide them refuge, in a sense. They don't have to engage in the risks and responsibilities, she said, of actually imposing the kind of changes they think are necessary, because they can just rely on the overarching principle. And I see that a lot too. You know, the students who, based on their papers, I think should be resistors, and they're not. And those actually end up being more compromise stories than restitution stories. Let me get to those. There we go. Journey. I'm doing these in the order that they came in. So the second category of stories were these journey stories, and this was, again, the 16%. And here, reluctant hero receives a call. She encounters trials and tribulations and challenges. She endures much suffering. She accomplishes her mission and returns to help others. This is the story of medical education, right? It's uplifting. It emphasizes the acquisition of knowledge. It can be overly romanticized, however. Now, so I said I was hopeful that there would be more journey stories. And again, I'm guilty of that overly romantic notion of what the journey should be. And again, sometimes it's appropriate. The students should be learning more, should be growing. And that's part of what they hire us to do, help them with their moral growth. But again, sometimes we don't really want them to grow if they're growing in the wrong directions. So, literary example, one of our favorites. Dorothy and Toto confronting the tornado. Lots of challenges. She's threatened by evil demons and monsters. She's assisted by friends and guides, all of whom she learns from. She gets help from the local medical doctor and a specialist, and goes on to have a happy ending. She's learned more, she appreciates her life more, and all order is restored with greater knowledge. A literary example, truly literary example, from Royard in 1992, where the patient examines the doctor. I would hope that my doctor's authority and his charisma might help to protect me against soul loss, a sense of terrible emptiness, a feeling that your soul has abandoned your ailing body like rats deserting a sinking ship. I would like my doctor to understand that beneath my surface cheerfulness, I feel the panic inherent in creation and the suction of infinity. He should be able to imagine the aloneness of the critically ill. I want him to be my Virgil, leading me through my purgatory or inferno, pointing out the sights as we go. I want a real journey, and I want my doctor to be my guide. And what the students wrote, I have learned that there are a plethora of different ideas and that different morals can coexist together. I have also learned to never turn a deaf ear to someone else's ideals. Experience is just as important as what can be found in a book. And patients are diverse. You can see the light bulbs going on, things that we think are obvious, but these are epiphanies for some of these students. They will come in all different shapes and sizes, vastly different cultures, and with a wide variety of beliefs and morals. And regardless of how difficult it is, we must treat each patient with the same compassion, empathy, and integrity as our favorite patient. It is important to realize that there are complex reasons behind any patient action. I know that patients will often make decisions that I wouldn't make because they have different priorities or beliefs. I now know not to become offended when a patient chooses something other than what I recommend. So you can almost hear these students learning, growing wiser as they tell these stories. Now, compromise, kind of the opposite. And here again, it's negative, in that the individual feels that he or she is conceding core personal values because of external pressures from the profession or professional expectations. Personal values are dispensed with for one of a number of reasons, either expediency, a desire not to cause trouble. Is this resonating with any of you medical educators in the room? Self-protection, or a lack of confidence in their personal perspective. And that's the, I just don't know enough, my attending knows so much more than I do, who am I to question his wisdom kinds of arguments. The person, the student here, may feel that this was the best I could do under the circumstances, or they may feel more disillusioned. And we saw both. Students who truly felt like maybe I need to reconsider what I'm doing for a living, and those who just thought this is the best I can do and that's all anyone can expect of me. So a literary example, famous story, William Carlos Williams, The Use of Force. Then I grasped the child's head with my left hand and tried to get the tongue to pressure between her teeth. She fought with clenched teeth desperately, but now I also had grown furious at a child. I tried to hold myself down, but I couldn't. I know how to expose a throat for inspection, and I did my best. Get me a smooth-handled spoon of some sort, I told the mother. We're going through with this. The child's mouth was already bleeding. Her tongue was cut, and she was screaming in wild, hysterical shrieks. Perhaps I should have desisted and come back in an hour or more. No doubt it would have been better. But the worst of it was that I, too, had got beyond reason. I could have torn the child apart in my own fury and enjoyed it. It was a pleasure to attack her. The damn little brat must be protected against her own idiocy, one says to oneself at such times. Now, if you read this whole story, you hear the regret. You hear that feel like he's forcing himself to do something because of the expectations. His job was to help save this child. There was an epidemic around him, and he needed to examine her to make sure she wasn't going to die. So you can feel the pressure that he's under, forcing him to behave in a way that he thinks is wrong. He's compromising his core values to do his job. And the mother expects it as well. The mother is egging him on as you read the story. So an example of a student story, I feel that in the future there will be a middle-of-the-road type of course of action that I may take in order to satisfy my professional obligations and perform my duty as a physician, yet somewhat meet my personal values, especially with regards to the greatest good. So here's a student who felt like she had to compromise her values in the situation she described, but is trying to learn from it. Is trying to learn that maybe compromise isn't a bad thing. So there's a tinge of journey here as well. Now the fourth category, witnessing. It's an ethical conflict that results in suffering that is watched authentically and compassionately, but can only be recorded, not resolved. That there is no immediately apparent solution is recognized. The emphasis is on clear-sighted caring and concern for the other, empathy for the other's suffering or the dilemma, a real effort to see through the other's eyes. So again, you're watching but can do nothing. Complexity of the moral issues is also acknowledged so that it's not negated or trivialized. It's not just written off as something I can't bother with. The category differs from chaos, in which the student feels the moral compass is swinging wildly out of control. Here the student calmly recognizes that there is no immediately apparent solution, but stays committed to the patient, rather than focusing on his or her own confusion. One's own complementary vulnerability and suffering is also recognized. So you're suffering along with the patient. One sees similarity, not difference, with the other. So this could happen to me kind of thinking. A famous example of witnessing, the 5 Stages of Grief poem by Linda Paston. It's a rather long poem, but it's a nice one, so I'll read it all to you. The night I lost you, someone pointed me towards the 5 stages of grief. Go that way, they said. This was written after she lost her husband. It's easy, like learning to climb stairs after the amputation. And so I climbed. Denial was first. I sat down at breakfast, carefully setting the table for 2. I passed you the toast. You sat there. I passed you the paper. You hid behind it. Anger seemed more familiar. I burned the toast, snatched the paper, and read the headlines myself. But they mentioned your departure, so I moved on to bargaining. What can I exchange for you? The silence after storms, my typing fingers. Before I could decide, depression came puffing up. A poor relation, its suitcase tied together with string. In the suitcase were bandages for the eyes and bottles of sleep. I slid all the way down the stairs, feeling nothing. And all the time, hope flashed on and off in defective neon. Hope was a signpost pointing straight in the air. Hope was my uncle's middle name. He died of it. After a year, I am still climbing, though my feet slip on your stone face. The tree line has long since disappeared. Green is a color I have forgotten. But now I see that what I am climbing towards, acceptance, written in capital letters, a special headline, acceptance, its name in lights. I struggle on, waving and shouting. Below, my whole life spreads its surf, all the landscapes I have ever known or dreamed of. Below, a fish jumps, the pulse in your neck. Acceptance, I finally reach it. But something is wrong. Grief is a circular staircase. I have lost you. So she can do nothing but accept what she's experiencing. Student example. We encountered a mother who had a long history of drug abuse. The baby boy, after his birth, had difficulties with withdrawal and has remained in the hospital. My heart breaks to think of this innocent child who's already been through so much, having to be raised in a home where drug addiction is a way of life. You can feel that student in pain, recognizing this child's suffering, feeling her own, knowing this child is going to go home to a place where this child shouldn't go. There was really no way for me to handle the situation, another student wrote, other than to accept it. So again, there was that sense of there was nothing I could do but stand back and feel badly. Resistance. Now we all know these students. These are the students who are activists. They're out there trying to change the world, one small or even large step at a time. One rejects conventional or professional ethics in favor of personal views, sets a course of battle and rejection, determined to stay true to his or her own moral precepts regardless of existing professional guidelines, especially once he or she is in a situation of greater power. So these are the, I will not eat that pharmaceutical company lunch and you can't make me kinds of students. Literary example, the war stories, Holocaust stories are the best examples here. And Schindler's List, one you're all familiar with, by Thomas Keneally. Whoever saves one life saves the entire world, was the tagline for that movie. Oskar Schindler uses Jews to start a factory in Poland during the war. He witnesses the horrors endured by the Jews and starts to save them. He is resisting the current regime. Our students tell these kinds of stories. Ultimately, I have accepted my decision, and this particular experience, although in the future I believe that I will opt for respectfully declining and asking to participate in another surgery. This was a student who was dragged into a termination procedure and later regretted it and said, no more, I will not do it again, and I don't care if the attending is standing at the door making me go into the room. Another student wrote, if I had been her physician, I would have followed the wishes of the mother. This course would have put me at odds with the majority view of the residents and senior physicians and the currently recommended treatment guidelines for this situation. The arrogance of believing that a medical education gives one the right to make life-altering decisions for another competent person is unchanged, despite the modern, more liberal culture of medicine. I don't care if my resident wanted me to do it, if my attending wanted me to do it, if the standard of practice requires that I do it. I will not do it once I am in a position of authority. That's the part in parentheses. So chaos. This is the anti-narrative because there really is no coherent story to tell here. There's a pileup of calamities, there's isolation and alienation, it's frightening or confusing to all involved, and there's no relationship between the characters. So it's not truly a story in the sense of storytelling, although it looks a lot like what we see on some of these TV doctor shows these days. ER comes to mind. This is what I think it might feel like. Famous painting of the Scream. And here's a famous example, Misery by Chekhov. Iona Potapov, the sledge driver, is all white like a ghost. He sits on the box without stirring, bent as double as the living body can be bent. The misery which has been for a brief space eased comes back again and tears his heart more cruelly than ever. His misery is immense, beyond all bounds. If Iona's heart were to burst and his misery to flow out, it would flood the whole world, it seems, but yet it is not seen. Iona drives a few paces away, bends himself double, and gives himself up to his misery. He feels it is no good to appeal to people. He can bear it no longer. Now, it's interesting writing a story about a person experiencing chaos because you have to give it more coherence than it actually has. This is a man who's lost his son. and the grief is so unbearable. His whole world, his whole story is coming apart. Now the student wrote, "The conflicting views on terminating pregnancies between this patient and I will probably never be resolved. I view her as an adult woman who has the right to make wise choices. She views conception as something to decide on after it occurs and figure out if the pregnancy is convenient to her at the time." So the reason this is a chaos story is the student was confused, frightened, overwhelmed by the situation around her, felt as if there was nothing that could be done. She felt alienated from the profession of medicine. Another student example. A woman had been pregnant 4 times and aborted 3 of her previous pregnancies. The one baby she did have, she gave up for adoption. She was an IV drug abuser and overall what I would consider to be a selfish and scummy person. I saw her because she had become pregnant again, had no idea who the father was, and desired another abortion. Her lack of responsibility and utter disregard for life were amazing to me. I happen to be pro-choice, but her situation seemed just ridiculous. My understanding was that she basically parties, gets loaded all the time, and has sex with whoever. She had no problem telling me this and was actually amused by it. Turned out that she also had a history of gonorrhea, HPV, and HIV. As a healthcare provider, I felt obligated to see her and help with the dilemma. It was tough because I did not like her and felt she was completely irresponsible and basically a slob. I feel that people should respect themselves and those around them. By continually terminating pregnancies because the patient doesn't have the foresight to use birth control or be careful, she is completely disregarding herself and a possible unborn child. This is an example of a patient's chaos story into which she's dragging the student. And the student really felt it. She struggled with this, and you can see that in the paper. And this is a common story, actually, it gets told in my class. And the students always struggle with this one. The number of papers I've had suggesting that we begin issuing parenting licenses is really overwhelming. Finally, no conflict. Encountered no problem. There was nothing to write about. And the reasons here I thought were really fascinating. Now, I want to preface this by describing my student body a little bit. I said before I have a very religious student body. And I, though I wouldn't put this in print anywhere, would actually go farther to describe them as prudish. I'm in Orange County. Yes, I am. And UCI is this liberal oasis in the middle of a very conservative county. But that hasn't affected the student body, only the faculty. And it was something of a commuter campus for a long time. A lot of our students, despite being in their mid to even late 20s, still live at home. A lot of them lived at home all through college. A lot of them have not dated, much less had sex or accidentally gotten pregnant or any of the things they see with their patients. Our patient population, it's not unusual to go in and find a pregnant 15-year-old who's making the tough decisions that go along with an accidental pregnancy. So for a 26-year-old who's, say, never dated, to be working with a 15-year-old who's pregnant for perhaps the 2nd or 3rd time, the cognitive dissonance there must be overwhelming. And so now for my students to describe themselves as open-minded and flexible while simultaneously writing in their papers that we need parenting licenses, I found very amusing. But that is one of the reasons they claim that they had not experienced conflicts for those who hadn't. That they treat everyone according to the golden rule, and that they're inexperienced, which I thought was actually an insightful recognition. They just don't know enough to really, truly understand when problems are confronting them. And that they just don't know any better, which makes me wonder a little about what they've been learning for the past 20-plus years. Student example of no problem. My personal beliefs are founded on being open and accepting of other people's values and trying to understand their points of view without imposing my own moral beliefs. Which all sounds well and good. A lot of this, though, I definitely got the sense was what they put down on the paper for the ethicist who's reading the assignment, more than what they really believe. Which actually was interesting because most of the papers I really felt like the students were writing the truth. The stories they told, they weren't whitewashing. They weren't whitewashing the values that they listed. And because they had not had the class before, they did the assignment before class, they didn't know what my expectations were. And for those who did email me in advance saying, what is it you want in this paper? My response is always, your honesty. Tell me what you're thinking. There's no right or wrong. And you're not being graded, so even if I don't like what you write, it doesn't matter. And they have no sense of what I actually believe either, because I don't lecture arguments at them. So except for things that I've published, so they know my views on physician-assisted suicide if they've bothered to take the time to Google me and find out. But otherwise, I have not published a lot of position papers. So they don't know. And so I tell them to tell me what they're thinking. But this is the one place where I really think they're trying to impress the ethicist, because they think it's good or right to be fair and open-minded. So my conclusion from the study is that the modernist find-it-and-fix-it medical model predominates over more nuanced analytic models in student analysis of ethical conflicts. So while it was only 38%, you could feel it more pervasive in the way they address problems generally. Because I have a number of other classes with them as well. When we do case analysis, they're always looking for that one overarching principle. That students appear to know commonly recognized principles of bioethics, but do not seem to have internalized or operationalized them. So knowing versus doing. And the personal values that they have appear to provide significant guidance in professional ethical conflicts. And I should add there, but they don't really recognize that. So they've got these values at play that they're not actually acknowledging. So for me, this, as an educator, creates a number of opportunities all around building news stories, creating new stories. It impresses on me the need for more empathic listening to help validate the student's experience, to connect with the students, to address their well-being, and to discover the hidden curriculum. We all know about the hidden curriculum, right? What the students actually are learning despite what we're teaching them. And a lot of that, I think, comes out in these assignments. That we're teaching them that autonomy is the overarching value. They're not making this stuff up. They have to be seeing it, I think, for the most part. We're teaching them that they need to find an overarching principle, and that overarching principle should be autonomy. We're teaching them to suppress a lot of their own feelings. But we're also role modeling the role of our personal values in what we're doing, and we're not always explaining our reasoning to the students. And that's my one consistent complaint about the clerkship model of medical education. We show the students what to do, but we don't tell them why. We don't give them the deeper understanding. There's also an opportunity to create new educational offerings based on what the students are telling us. So we can use these kinds of stories to identify their educational needs and incorporate new lessons. We can also collaborate with them to revision and reconstruct the stories that they're telling. We, in our vast wisdom and experience, can offer alternatives that may change the kind of story they tell. And we can role model the kinds of storytelling we want them to do. And we can role model, even more importantly, this sort of reflective practice to show them that we are thinking about what we're doing, that we're not just doing it. And then to help them develop a better story, which led me to start wondering, well, what would be a better story? Because as I said before, none of these story types are bad in and of themselves. They just might not be the most appropriate story for that situation, or the story that the student feels the best about. So we need a story for a situation that makes more sense, that provides more meaning, and that gives more hope and happiness. Which doesn't mean the problem's resolved. It just means the student feels like their role is helpful, that it's not for nothing, and that they're not going to toss and turn. The implications for medical education, I think we need to provide more opportunities for self-reflection. We spend a lot of time telling them what to do and what they have to know. We don't give them a lot of time to actually think about what we've asked them to do. And so they struggle with it. And I suspect that might be partly to do with why the divorce rate in medicine is so high. because they take that stuff home and they have to do something with it. So the significant others get dumped on and don't always like that because they're not necessarily prepared to be the dumpee. It can offer guidance for more in-depth analysis. We can learn more from what they're telling us to inform education. We can use these kinds of stories to enhance our role modeling, thinking about what kind of stories we want our students to be telling. What do I want my students to get out of these experiences? And then to incorporate ethical principles clinically, so they actually know how to use respect for autonomy, beneficence, and non-maleficence, that they're not just these meaningless labels. So we want to habituate usage, get them from knows to does, which you might recognize this chart. The student starts with the know, goes to the knows how, the shows how, and finally the does. And it'd be nice if we could get them to the does instead of the just knows. We want to move them from knowing to doing, cognating to behaving. Finally, the acknowledgments. I already mentioned Dr. Shapiro and Dr. Lee. Dr. Boker is actually our biostatistician, who's actually closer to here now. He's in Pennsylvania. He left us a year ago. Leanne Lang is the undergraduate student who really did read all 299 and did the initial coding. And Fran Stevens ran the numbers for us. That's it. Thank you. Question?
I'm sorry, I believe, but I wanted to ask you this question. So when you did the content analysis, did you use software? Did you come up with your own categories? Did you do patterns? I mean, how did you do that so that you could create a structure on which to generate the intellectual reliability that you wanted?
Well, it took us 6 months. And since I had 5 years' worth of papers, we pulled out 10 of them. And the 4 of us read the 10 and started scribbling down our ideas for the categories. We didn't use software. We created the whole coding scheme ourselves. And our coding instruction booklet is about 6 pages long. So we went through question by question. And we pulled out some of the demographic stuff, some of the things that the students weren't directly asked, and then, of course, added on the narrative stuff at the end. So the spreadsheet is enormous. I don't actually even have it on my computer because it just took up too much space and we can't print it out. And so our Fran Stevens has it, our data runner. And it took, as I said, about 6 months to go through and really refine it. We kept using sets of 10 papers until we got there. And then we did check the inter-rater reliability on a set of 30 papers. And our initial reliability was only about 50%. We thought, well, that's not going to be acceptable. So we kept refining the narrative. Actually, it was very high for everything except the narrative categories. It was in the 90s for everything but that. So we kept going with the narrative categories until we got up to about 75%.
Thank you.
Mm-hmm. David?
You may want to hear the question, which has no time for the answer because we'll be web streaming it. But I had a question as to whether you thought about doing something more longitudinal in taking a cohort of students and then tracking them to see what happens in terms of their reflective evolution over time.
Mm-hmm.
And so, for instance, one could do it just randomly at different times during the course of their development through medical school and even off into residency if they stay in Sierra Vine. And the other thing too is it gets specific guideposts of interactions with patients or in their experiences, such as in an anatomy class, first preceptorship where they saw someone who was critically ill, the first patient that they took care of on the surgery service, the first death that they had to attend in terms of divulging to a family that a patient has died, that sort of thing. And then have them, you'd actually be able to see an arc of moral development and narrative development as you go through tracking a specific person. And you now really need IRB approval. But the thing is that at least you have some interesting things about how they develop over time.
David's asking if we've considered doing this longitudinally. I'd love to. The problem is actually getting them to do an assignment like this and make it worthwhile. And you all probably had this experience with medical students. If you make them do the same thing twice, they have a lot to say about that. So I don't know that we could without telling them this is for a study. And then some of them might be willing to participate. I don't know that we have the time built into the curriculum to make it a meaningful experience at the different guideposts. There are other assignments I give, and it'd be nice if I could find a way to look at those. I've actually created one assignment now where I have them describe some of their values in the first year, so I can at least get some of the lists that might show similarities or differences over time. But this is the first year I'm going to be doing that, so I'll see if it actually turns out to be useful in that way.
I think the problem with trying to do something, and you hit on it as well, is that reflective writing really has to be part of the culture. It can't be an isolated assignment, because then you run the risk that it's not really reflective. It's, as you said, giving them what you want to hear. And students are so consumed with, is it on the boards? Is this, do I have time for this? So there is a small percentage of students either for whom reflective writing or journaling is something they've already incorporated into personal lives. Or perhaps they were in the humanities as an undergraduate and really developed an appreciation for writing and reading. But even many of those who are like that just really can't give it the time that it needs. We've been toying with the idea of the humanism portfolio for several years, but the drawback is, as you said, it's very, very difficult to, if it's not part of the culture, just like an honor code.
Right.
It has to be lived and breathed. We just don't have that culture here.
Right. She's saying part of the problem with doing this is that reflective writing needs to be part of the culture. And if it's not already built in, it's difficult to create time to get students to do it and to take it seriously so you get something meaningful from it. And we do have an outlet. We have an arts journal called Plexus that the students do work on and contribute their work to, and is published once a year. And the students who are really interested in this kind of stuff contribute to that. But the students don't consistently do this writing. They're used to it with me. I see them a lot during their third year, and I'm in most of their clerkships, and they write for all of my sessions. And I've discovered my assignments are very popular. Virtually all of my assignments are used in the student portfolio, except for this one because we said no. The other ones aren't quite as sensitive. They bring a patient safety issue, they bring an ethical case for analysis. They're not quite as touchy because they're not specifically being asked for their personal values. So this one we've pulled out. So they are used to it from me. And if I was just looking across the third year, I might be able to do 1 year longitude. But across all 4 years, it's just not there yet. And I'm a program of one. I'm one faculty in ethics, and that's it. We do have someone who teaches humanities. Johanna Shapiro teaches humanities, but hers are all elective.
I really appreciate these categories that you put. They're quite imaginative and provocative. But it occurs to me that the one about witnessing illustrates something that seems almost typical of all of them, and that is that the focus on the physician, student, never gets beyond the superficial. They are the answer giver or the fixer, or the observer as in witnessing. Why could they not be the other side of witnessing, namely share the story, in which the physician really becomes person to the patient as person? And in telling the story, you avoid paternalism. You're not telling them what to do. But you at least have the benefit of an outlet of saying, here's my story. It may be beneficial, but it's important for this context. Does that make any sense?
It does. He's suggesting that the witnessing category sticks us in this observer role, and that we could be on the other side of the witnessing, the storyteller. And I think that's part of what they use my class for. But they feel, and this is where I was saying at the beginning, they have some interesting notions of professionalism. So we spend a lot of time talking about those kinds of values because they all claim they need to behave professionally. That's one of their professional values. And I asked them what that means. And almost to a one, it means this notion of professional distance and objectivity. That to be a professional means you can't share your personal experiences. You can't impose your personal values. And they don't understand the distinction between sharing and imposing. That to suggest I've had a similar experience to a patient would be telling the patient what to do in their minds. They can't distinguish them. And they don't think it's appropriate. That once they put on that white coat, they have to be this, it's almost like putting on a mask. They can't share their personal identity. And they almost universally think it's bad to reveal personal stories. And I use a lot of my own stories in class. And my stories as patients, my stories of when my children have been sick, we all have these stories. And I think they have great teaching value. And so at the end of class, I ask, well, so did I behave unprofessionally as a teacher in sharing my personal experience? And they always say no. They like those stories. In fact, that's one of the things they like most about my classes, that I do tell these stories. So I ask them why they don't think their patients would have the same appreciation for their stories. And I try to help them understand that they don't have to impose. That because I chose to have the mastectomy instead of the lumpectomy doesn't mean that that's what I'm telling you you should have to do. I'm just sharing my experience to show you that I'm here with you, that I'm not just the technician providing the care.
Rob was first.
Yeah. I have a question in context. I'm a family doc, and I'm teaching in a school of public health. And I'm currently dealing, with issues related to the limits of autonomy from a societal perspective, where benefits to many, is really the issue, with the implicit notion that there are some people who aren't going to gain and some people who are, may not win, from a policy, decision. So, I've recently learned that this is perhaps a utilitarian perspective. But my issue is, how to make a bridge. I mean, your students are learning about ethics and autonomy, and I think they're learning it as a tool to be applied more as a quality of relationship. If students go on and become involved in community health, then I think that notion of autonomy needs to be modified, in some way.
Mm-hmm.
I was wondering if you had any comments to help me out of the dilemma.
Yes. He's asking about this bridge between medicine and public health, how we use that notion of autonomy, which tends to guide physician-patient relationships rather than community relationships, how we can still use that. I've long harbored this fantasy that all medical students should have to do some work in public health. I think it'd be life lessons in justice, not just in the notion of autonomy, but to actually understand how complex the principle of justice is. And I think that's part of the solution, that when we teach them about respect for autonomy, we teach them that it is one principle among many. And it's not just the Georgetown mantra of principles. It's not just beneficence, non-maleficence, justice, and autonomy. That it's compassion and altruism. That there's an array of principles and values out there, and that all of them are just one among others. And that in every situation, they have to be prioritized appropriate to that situation. Now, there is this tendency to autonomy is always on top. And I don't think that's right. It seems like it in this culture, and California being one of the most litigious places on the planet, that always comes out on top. But it's going to require some culture change within medicine and within society to explain to people that it's not always about getting what you want. And then the nuances of autonomy itself, it's become almost synonymous with consumerism. That autonomy means we give the person whatever they want. And that's not what autonomy means. It means we encourage self-governance and respect what the person is telling us. But that doesn't mean we necessarily act on what they've asked us to do. And that's where students really freeze. They don't understand how they can say no. So we end up with patients in our ICUs for months and months and months getting inappropriate care because nobody has learned how to say no. That's not appropriate. It doesn't balance with the other values involved here. So it's really this notion of prioritizing and balancing that we have to do a better job with.
I have a story to tell, and the story is when I was going on rounds with surgery here, we had a patient who had been in a car wreck, about 26 or 27 years old. Had the only problem he really had was he smashed his foot up to above the ankle. They were going to have to remove his foot, from the ankle on down, and he was refusing the operation. And as the residents talked to him, they found out the reason he was refusing it is because he always thought of himself as a basketball player. That's what he wanted to do. He wanted to be a professional basketball player. And in his mind, he had been killed in an automobile accident, and he said he did not have a future. And we talked about different things to do, but I finally, in our frustration, just ended up saying, look, his problem is with his identity. He's going to have to change his personal identity before he can at least see it as possible in order for him to accept this operation. And I left it at that. Several years later, I learned from one of the people who had graduated from surgeon that that's exactly what they did do. They said since we were his age, we stopped the whole informed consent business. We tried to scare him into getting the operation by talking about the gangrene and all of that, and that wasn't working. So we just started talking to him as somebody as buddies, somebody his age who was looking forward to a profession of a certain kind. And as we talked to him just as buddies with facing a future and having planned for it and hoping for it, he came to see that he could have a different future and he could sit in the operation. So but they had to switch gears. They had to get out of the official informed consent role and just really start talking.
He was telling a story about a patient who was refusing a procedure that he needed. The only way to get the patient to consent was to help the patient change his identity, which meant changing the consent process. And I would say they just did a better job of informed consent. I make my students do a values history on a patient also in the third year. And they always come back to me and say, oh, these questions are only appropriate for our dying patients. What gives their life meaning doesn't matter to me until they're dying. And I need them to help them find the support they need to appreciate this time of their lives. And I always remind them of stories like the one you told, a young man who's had an accident and is refusing a procedure. He's not dying, but his life is changing. And you need to find a way to help him get the medical care he needs and to go on with his life. And unless we know more about our patients, we can't provide that kind of help. We can't get them the optimal medical care unless we can help them understand how it fits into their life. And how it fits into their life is it may change once they get the medical care.
The residents have to switch gears and not do what they've been told to do so much, not strict what they've been told to do.
Right. So they have to pull back from this imposing autonomy is really what they were trying to do, manipulating the autonomy, and to a more compassionate approach. Again, that balancing of values involved is very important.
Was there any, going back to the autonomy thought, were there any narratives where students who were firm believers in autonomy going into it, whatever their conception was, found that belief challenged by a patient or a patient's family who did not want to make the decisions? I come from a pediatric intensive care unit over here in Cohn. We don't see that infrequently where family really wants the doctor to share the moral burden of, say, withdrawing support on a child or something, where they can see in their mind that it might be the right thing for their family to do, but they don't want to be the ones to say it. But you could see how for some conception of autonomy that would be a big challenge to that. Did any of that come out, or was that unavoidable?
Right. He was asking if there were stories where the student's conception of autonomy was challenged. And almost every story. The students don't understand why somebody wouldn't want to make the decision for themselves. As young, healthy people, there's a lot of projecting going on. I, of course, would want to make this decision, and I don't want my doctor to bother me with all these things. So they assume that that's what their patients want as well. And I always ask them, how many of you have had a patient ask, what would you do? What the patient is asking for is help. Help inform my decision. And a lot of patients will just say, I don't want to decide. You tell me what's best, and that's what I'm going to do. That's what they come to us for. The students really struggle with that because paternalism is bad, right? It's gotten a bad rap. And sometimes parenting is exactly what our patients want from us. They want somebody to help make decisions. Of course, we have to be careful because we don't want them coming back to blame us if something goes badly. We have to carefully document that, how a decision was made. But at the same time, I don't think it's wrong to assume that role if you've worked it out with the patient that way. The students really struggle with that because of our society's emphasis on autonomy. You have to make your own decision. They have much less trouble with it with the unconscious patient. But I get ethics consult requests all the time because the patient's asking for something the doctors don't think is right, but they don't feel like they can say anything because the patient's made a decision. I just did an entire conference with the OBGYN and pediatrics and neonatal units because they had 3 cases of hypoplastic left heart, and they were unhappy with the decisions made in all 3. And I could feel it in the room. They're struggling with we wanted to tell the families what to do, but we can't do that because that wouldn't be professional. So we spent a lot of time in this large group sorting out this notion of professionalism and sorting out this feeling that they all did badly because they couldn't impose their views on the patient. So yeah, that's a constant struggle. And it's medicine is a microcosm of the larger society, and I think we struggle with this notion of autonomy in our society generally. It's become so predominant that it's hard to get around it. We've lost that notion of greater good.
Thank you very, very much.
Thank you all.